Invite the next speaker. Any questions for Amar? Please ask. Invite next speaker, who is also one of the most brilliant surgeons that we have in the country. Dr. Tanvi Haldipurkar, as the name suggests, she's the daughter of Dr. Suhas Haldipurkar, but she has huge volume and they have an excellent team doing brilliant work. Yeah.
Hi. Thank you so much for the introduction, sir. Because of courageous surgeons like you, Dr. Agarwal, sir, and so many others, I think we've got a fair idea of how to deal with things when they come to us. So today I'm going to talk about managing post-traumatic dislocated lens back complex. One would think that traumatic dislocation is something only a super specialized surgeon may have to encounter, but I think that's changing, and it could be a trivial trauma or just a hard blow, but for some reason or the other, we've been getting a lot of these cases coming to us. So let's try and understand what exactly is happening. So we know that there is a blunt force that gets applied on mainly the anteroposterior direction on the eye, and this leads to an equatorial expansion, which will cause the zonules, the zonular fibers, which are inelastic, to kind of disrupt, and that in the end lands up dislocating the lens back, which could either be anteriorly or into the posterior segment. These zonular fibers are tiny, they are thread-like, inelastic structures which connect the lens to the ciliary body, and their strength is obviously crucial for maintaining the lens stability as well as accommodation. Now, when I was trying to understand whether could there be something we can do in the primary setting, because there are patients who have pseudoexfoliation, Marfan syndrome, or they just present to us with an initial subluxated cataract, and can we do something to them in the initial visit which could help them later in the past? And we used to use a lot of CTRs, and this study kind of made me rethink, because they did a series, or they looked at a series of 23 cases almost, and they found it that in the long term, whether you use CTR or not, there is going to be subluxation after 6 to 8 years. So I think that now the understanding is that along with the CTR, maybe you need to fix the bag externally to the sclera somehow, or in any other way, which requires an additional support, because otherwise be prepared in the next 8 years to do a refixation. So we saw in the initial talks about how the patient may present to you. Now, since we are dealing with traumatic subluxation, we know that the patient will give you a history of trauma. Sometimes it may be so trivial that he just, got up, bumped his head, and he may not even realize that he had a problem until a few weeks later. But you can get few subtle signs on clinical examination. So you could see pseudophacodonosis. You may see that the iridolenticular gap is more. You can ask him to look on either side, maybe on lateral gaze. You may see that the bag equator is seen very well. There could be focal iridodonosis, but then you may also see such a frank dislocation right into the vitreous, or you could just see some haptic into the anterior chamber. Whatever may be the cause of how the traumatic subluxation has happened, there are certain principles of management that we can follow which will guide you as to how to treat a case. So in the initial, when the patient first presents to you, you have to do a good, complete clinical examination. That includes history. If the patient already has had pseudoexfoliation, you may see some flaky dandruff material, then you're expecting that this can be a pre-existing zonular dehiscence, and now that trivial trauma has just caused a further dislocation. You need to know what is the type of trauma. If it was something small, limited to the subluxation of the lens back complex, then you're okay. Otherwise, it becomes a sort of combined approach with your vitreous surgeon and vitreoretinal surgeon, because there could be vitreous hemorrhage, ciliary body dialysis, and so many other problems that could be a part of it. So a good gonioscopy can help you understand how the angle is, do a B scan or a UBM, and then assess for the clock hours of break. We need to know, can we fix the same? Can we use another lens? Presence of vitreous will tell you whether you do an anterior or posterior approach. And then, of course, the most important, whether are you going to use the same lens or would you like to exchange it? Today, I'm going to show you 3 cases where we have done some way of management for that eye, but most of the cases that we have approached till today, we've had to use only these surgical instruments and tools. And I think if everybody have these simple tools in their OT, you're fit to be a surgeon who can treat these traumatic subluxations. So now the first case was of a patient who unfortunately also had a few clock hours of subluxation to begin with, and hence we had put a Sionese modified capsular tension ring in his primary surgery. And he came a few months later, probably I think few years later, saying that he had a trivial trauma, and the suture that was taken through that CTR had broken. So now we were in a position to refix that same CTR. So here we are using a 90 proline with a straight needle. We have done a conjunctival flap. We've gone from the sclera, looped it through that hole, gotten the suture out, and then threaded it back onto the sclera and fixed it. Here, since along with the trauma, there was a little bit of mydriasis, so we also used the single pass 4-throw technique for pupilloplasty. And you can see that in the end, the patient had very good vision. Or rather, the postoperative outcome was exactly how he had before the trauma. The next case is of a patient who, after a trauma, he hit his head while getting up, and after the next day that he got up, he said that he can't really see very well. And when we examined him, we found that part of his lens back complex was subluxated anteriorly into the anterior chamber. On dilatation, we found that the rest of the zonules were fairly stable. Now, this is something of importance that if it is not a case of pseudoexfoliation or Marfan's or any pre-existing zonular pathology, most of the other zonules are pretty strong. Only the part which may have subluxated is something that you need to look out for. Since the bag was fairly fibrous, we decided to do a belt loop sort of a suture just around the haptic that had come out or broken. So we just tucked the lens back into its original area, and then we used again a 90 proline with straight needles, and here we are using a 26 gauge needle 2 millimeters behind the limbus. We have tracked it from the sclera behind the iris on top of the lens first. We have railroaded the suture out, and then the next loop goes under the haptic and through the sclera out. In the end, once you are looking at the 3 reflections, Purkinje images on the cornea, you will then tighten the suture depending on where you want to pull it and fix it. So this is a fairly good way where if there is no vitreous disturbance, you have really gotten away with doing just a minimal intervention. And this is the image of the patient on first post-op day. The third and the last video that I'm going to show was very recent. He's just come to us last week. Probably he knew we are coming for AIOS, and he came with a trauma. There were some people having a fight, and he just wanted to stop them from fighting. And in that process, he himself got a nasal blow. And this is the lens that has come out nasally, anteriorly subluxated, the entire lens back complex. Now, as you can see, that this is a multifocal lens. Now, we cannot think of probably taking it out because the other eye is also enjoying a very good vision of 6/6N6. So now our plan here was that we will plan and refix this entire bag lens complex onto the sclera again. In this case, we have used the AIOS anchor with a with NRI diamond blade. We have just made an incision, and now a Hoffman's pocket will be created, or rather was done, with a 1.25 millimeter keratome. As you can see, there is very minimal vitreous displacement over here. The posterior capsule was incidentally opened up post-yak capsulotomy, but the anterior capsule was quite intact. So a 26 gauge needle was used. We insinuated a little bit of space, put high molecular weight viscoelastic to make that space even larger. Now we are using capsular hooks to just stabilize the bag while we then go and introduce the AIOS anchor to suture this entire lens back complex onto the sclera. That Hoffman's pocket is a very good way of suturing or keeping the sutures buried. You could also do a conjunctival flap, but this is a little more patient-friendly approach. So now we are planning to go through the Hoffman pocket. Again, a 90 proline with straight needle is used. First, the direction should be towards the posterior pole, and then maybe you can use another instrument like a spatula to redirect it so that it comes just above the entire lens back complex, and then you railroad it out, either using a forceps, but what we use is like a visco cannula, which has a slightly thicker opening, so then it can very easily come through that. You can also do it with a 26 gauge needle, but maybe sometimes the dexterity of putting a smaller thing into a smaller one is not so easy. So a visco cannula really does the trick very well. So once one loop is out, we use that same needle to then track through the AIOS anchor, and then the same needle can go back in. So here you don't even need to use both the double ends of the straight 9-proline suture. So now from the other side of the sclera, we are using a 26 gauge needle. Again, the same path, posterior pole directing, and then just lifting the iris up and coming behind the iris, but in front of the lens back complex. And then the same needle has looped and tracked out through the sclera. So now is more the kind of the tricky part, but I think it's quite challenging and fun, is that now you have to hook the AIOS anchor onto the anterior capsule. And as you can see, the AIOS anchor has a T-shaped end, which kind of goes under the anterior capsule and it holds it. The rest of it is flush to the sclera, and you can pull it according to however you want the tightening of the bag. So in this case, there was very minimal vitreous disturbance, but you could still put a little bit of triamcinolone and look out for if there is any kind of vitreous. Then the sutures need to be tightened. So here we have put a little bit of pilocarpine, gotten the pupil down, and then taken the suture out from the Hoffman pocket and then tied it. Here you could use a light pipe to just for a better visualization, since that area is under the Hoffman pocket and it may not be so clear. But once this tightening is done, the sutures are very well buried and the patient really does not feel anything on the first post-op day. So cases like these can also get an excellent outcome without even requiring to use your vitrectomy machine, but that's not the message. You have to look out for the most minimal the things that you can do which will give you a good outcome. So my take-home messages will be that there will be lens back complications that you will encounter, considering we are off late seeing a lot of dead back syndromes as well. So we need to be prepared. On this podium today, we have seen a lot of different ways of making sure that we can fix the lens onto the back. But we have to remember that it is a tailored approach. Each eye will behave differently, will come with a different set of trauma, and we have to accordingly manage. But careful management can definitely result in a good visual rehabilitation. Thank you so much.
Thank you, Dr. Tanvi. Fantastic presentation as usual.